C'est parti.
Ok.
Welcome everyone. We're going to wait as usual 2 minutes for people to join the webinar. Thank you. So good morning, good afternoon, or good evening. My name is Guillaume. I work in the Department of Maternal, Newborn, Child and Adolescent Health in the World Health Organization, and I'm very happy to welcome you for this webinar. Some house rules, as usual, that Benedict put in top of the chat. Everybody is muted on entry, and we only unmute the speakers. We'll have the question and answer session in the chat room, just in the chat room, so just post your questions there and send them to all participants so we can all see them. During the presentation, don't wait the last minute. My colleague Benedict will moderate them and read them aloud. Any questions that we don't have time to answer during the webinar, it will be entered on the website in the next days. So today's session is the fourth step of the series Point of Care, Quality Improvement for Maternal and Newborn Health. The last three webinars have described the identification of problems, setting up teams for improvement and measurement, and developing and testing changes to improve the quality of care. Today, this webinar will focus on the ideas for quality improvement tips to hardwire a quality improvement project in order to prevent the system from slipping back to the old ways of working and ensure that the improvement is a system change, not just a minor tinkering, and build more enthusiasm among health workers for quality improvement. Today we have one speaker, it's Nigel Lively, he's the Regional Director for USAID Assist, and during his presentation we will have 4 polls of 30 seconds each, which will appear in the lower part of your screen. So now I can give the floor to Nigel. Welcome, Nigel.
Great, thank you very much. Can you hear me okay?
Yes.
Great, okay,
Yeah.
Perfect. Thanks, everybody. So let me start by sharing a story from a hospital in Uganda that was trying to improve nutrition care for people with HIV. So the graph is looking at how many people had their nutrition status assessed, and the x-axis is showing time. So weeks minus 20 to 0 is the baseline period before anything was happening, and then weeks 1 to 26 is after the facility started trying to improve this and provide more assessment to people. So as you can see at the beginning, nobody was getting assessed. This very rapidly increased, and so everybody was getting assessed, and then almost as rapidly started going back down to baseline. So let me change continents and change topic areas and share some work from hospitals in India that were trying to improve delivery care. And so you can see that these hospitals, most women were not getting oxytocin and most babies were not getting essential newborn care. Again, this increased very rapidly once they started trying to improve this, and it decreased almost as rapidly on its way back down to the baseline. And so this scenario is common. In fact, it's probably the norm. You know, if you go to a facility and ask them to try and improve something, they almost always do. And you will often get a few weeks or potentially a few months of improvement, but it's often not sustained. It's usually not sustained. So this is a common situation, but it's not inevitable. And both of these cases, these facilities managed to change what they were doing and to sustain the improvements. Both of these are showing 6 months of data, but all of these facilities sustained improvement at least a year after this data as well. And so today I'm going to be talking about what happened here. So I'm going to talk about the first phase, how they came up with non-sustainable improvement, and the teaching points are really going to be don't do this. And then I'm going to talk about the more sustained improvement, and the teaching points will be do this. So I will speak about both of these in some level of detail, and then I'm going to end the presentation with some general principles about sustainability that are drawn from the literature and from other sources. But let me start by talking about what not to do, how to not sustain improvement. So let's go back to the hospital in Uganda. The reason why nobody was getting a nutrition assessment at the beginning was because this is 10 years ago now. The clinic had really just been set up to give out antiretroviral treatment and wasn't really doing holistic care. the government wanted to change that and for clinics to start doing more holistic care for people with HIV, and nutrition care was a big part of that. So an external group was asked to come and support this facility. They trained the staff in the facility on how to look after people, how to identify and look after people who are malnourished, and they also provided commodities in the form of measuring tapes to measure mid-upper arm circumference, or MUAC, to identify who is malnourished, and they also provided food for giving people who were identified as being malnourished. So after they did that, as we've seen, there was a rapid increase, and then almost as rapid a decrease. And so I'm interested in your thoughts on this. What do you think happened? So we have a poll that Bene is going to open up in a second.
There he is.
What do you think happened here? Why did performance suddenly go from 0 to 100% and then rapidly decrease? Was it because that the people who were trained were transferred out of the clinic, supplies ran out, staff lost motivation, or was it because there was external pressure from an inspector who was there for a short period of time? If you could list which of those you think is the most likely, and then we will move on. Bene, are you able to show the results?
Yeah, I need to wait another 6
seconds. Oh, just a second. Okay, sorry.
To give people a chance. Okay, I will show you the results now.
Okay, great. Okay, so no answer. I mean, that's probably sensible. If you don't know this clinic, then maybe it's hard to guess. But the answer is that there was an inspector there. So the regional supervisor was there for one day to see how the program was going. And on that day, everything was good. But the supervisor wasn't actually seeing patients. So what did the staff do differently that led to this increase? Do you think while the supervisor was there, the staff identified the barriers to assessing nutrition status and developed solutions? Do you think they found out what patients wanted, or do you think they worked extra hard that day?
Okay, I'm opening the poll. You can now put your answers. You have 30 seconds. You see it?
I see it. So yeah, people just want to click A, B, or C.
Okay. I don't see anyone answering, so I'm supposing there's a problem.
Ah.
I see 0 attendees have responded, and the remaining time.
Someone
okay,
is
let
saying
me try it again.
submit is not working.
Okay, let me try it again. Sorry about that. We tried this a few times before, believe it or not.
Yeah, it worked half an hour ago.
All right, now it should work. Go.
Great. Thanks, Mike.
10 seconds left. Okay, I'm going to display the result in 10 seconds now. It takes a while to compile it. There we go.
Great. Yeah, so working extra hard. That's what you do when the boss is there, right? When the Minister of Health comes to your clinic, that clinic is pretty clean. Doesn't mean it's going to be clean a week from now. So the staff responded to all of this by working hard. So they were getting the standards, the resources, the training and inspection, and their response was to work hard. And they were also measuring performance. And, you know, working hard and measuring how you're doing, and even when you see that you're not doing well, these are not sustainable. Okay? So I'm now going to go into some details about what working hard means in this situation and how this clinic stopped working hard and started working in a smarter way, in a way that was more sustainable. Okay, so at the beginning, when the program was not set up to have anything to do with nutrition, a clinic visit looked like this. The patient would come in, would get registered, would go and see the medical officer, would then go and see the nursing officer to talk about medication adherence, would then go and see the pharmacist to get the medication, and then would be discharged home. And so when the staff knew that the supervisor was coming, they didn't change anything. They didn't change the patient flow. They just asked everybody to do more work. And so the plan was that everybody, all of the clinicians would do the nutrition assessment, would measure the mid-upper arm circumference. So the registration clerk, the medical officer, the nursing officer would all do this. And measuring the MUAC takes maybe 1 or 2 minutes. But there are 100 patients coming to this clinic. So 1 or 2 minutes times 100, plus all of the redundancy, because some people were getting measured more than once, led to a lot of extra time. And the clinic ended up closing after 8 p.m. Families of the patients and the providers were not happy. The only person in the world who was happy was the supervisor, because he or she could see that everybody was getting an assessment. But as soon as the pressure of the inspector is gone, people aren't going to keep that up. They are not going to agree to go home at 8:30 every night, and patients aren't going to agree to wait another couple of hours because somebody wants to measure their arm. And so what happened is that they still tried to do it, but as they got busier, they skipped it. And the nurses didn't do it because they thought the medical officer was also doing it. The medical officer didn't do it because he or she thought that the registration people were doing it. So everybody just expected somebody else to do the work. They realized that this was happening, so the next thing that they did was set up a new station in between registration and seeing the medical officer, where a nurse was assigned specifically to do all of the nutrition assessments. And this change led to about 60–70% of people who came to the clinics getting assessed. So what are your thoughts about this? Why do you think that this newer system was able to assess 60–70%, but not 100% of all clients? Do you think this was because the nurse in the assessment station was not motivated? She did it for some patients, but not for others. Or because she was too busy, there were too many patients and just one person was not enough, or because patients didn't want to spend time in the clinic and so they skipped the nutrition assessment. What are your thoughts? If we could put up the poll. Great.
The poll is open now. Here are the results.
Great. So, yeah, all of these are potential options, but the situation here was that people were busy. They didn't want to spend extra time waiting in an extra queue, and so they just skipped going into the nutrition station. So the nurse was doing a good job. Everybody who came to her station got an assessment. She was doing a great job. But if people don't come, there's not much she can do about that. So what should the facility do now to fix this problem? We don't want to assess 2/3 of the patients. We want to assess everybody. So should they educate patients on the importance of nutrition assessment and care so that they will want to go to the station? Should they make them go by not giving out their drugs unless they've gone, because nutrition is important? Or should they change the system so that it's easier for patients to get a nutrition assessment? So we've got about 30 seconds. If you could put your thoughts down, please. Okay, so yeah, people want to change the system. So exactly right, right? That's not what actually happened. The facility did try the first two first. You know, they did try and make the patients work with the system rather than make the system work for the patients, but they did eventually change that because it wasn't working, right? You can make health workers work hard, but you can't quite as easily make patients work hard. So what they did was really create time. You know, doing an extra 200 minutes of work, which is what the MUAC takes, means you need to find that extra time. And they did two things to make that happen. One, they asked for volunteers, so they had expert patients who lived close to the clinic come and help measure the MUAC. And they also set up a triage system so that not every patient had to see both the nurse and the medical officer, but the sick people went to the medical officer and the healthier people went to see the nursing officer. And so now the system works well for everybody, okay? And it worked well and it was sustained. And that's because it's easier. You know, it's less work and less time consuming for everybody. They are doing less work and they're getting out of there faster. It's also beneficial. You know, about 15% of people who came to the clinic were malnourished. They were identified and treated, which is really nice. And also this change itself was owned by the staff in the clinic. They came up with this. They organized it themselves. It worked for them and they were proud of it. And so because of that, they kept it going. It was their baby. So let me move over to India now. And as you can see, we have, you know, a few facilities which are not doing great. And this work happened in a larger context. This is at a district level, and the district had started a quality improvement program a few months earlier, and 5 facilities were getting support from quality improvement coaches to fix oxytocin and essential newborn care. And they managed to get very good results very quickly. And so the district asked the other 38 facilities in the district to do the same thing. And they were setting up a mechanism to provide quality improvement support to these facilities. But while they were doing that, they also did the usual stuff. They gave these facilities standards, they provided clinical training, and they asked them to give monthly reports on how well they were doing with the oxytocin and essential newborn care. And so the facility staff reacted to this support by doing the best that they could, by trying to work harder and by doing what they were told by measuring performance. And this again led to some improvement, but it wasn't sustained. You know, hard work can't be kept up indefinitely. And one of the nurses who worked at one of these red hospitals explained it, that they were given instructions from the senior doctor to give oxytocin and to keep babies warm and to give vitamin K. And they did their best. They got some improvement, but they were not able to sustain the high levels of results seen in the QI facilities, and they didn't know why. But then the approach changed. The district set up its system to provide quality improvement support to these facilities. The coaches started going in September 2014 and helping them do what we've been talking about with this webinar series. They identified what was inefficient in their system, and then they changed their work to make it less inefficient. So they were preloading syringes of oxytocin before the delivery, so they had it available when the baby came out, and they reorganized the labor room so it made it easier to provide care to both the mothers and the babies. And then the frontline workers themselves adapted and adjusted these changes until they worked for them. So we've been talking for the last few webinars about these steps that Guillaume was mentioning. You know, identifying a problem and forming a team, and analyzing what's going on, finding efficiencies and then addressing them, developing and testing changes until you make it work in your context, and then the fourth step is sustaining change. But really, sustainability starts with step one. If the frontline workers are not involved from the beginning in making sure that the changes are feasible, that they address the real problems, and that can be adapted to the real world, you're not going to get sustainability. You know, hard work will only take you so far. It needs to work for the frontline workers. And this idea is supported by the literature as well. So about 10 years ago, the NHS in the UK reviewed all of the literature on healthcare improvement and sustainability and had an expert consultation and developed a model which has 4 components that are important in sustaining improvement. And the first one is there are characteristics about the new way of working that make things more or less sustainable. Involving the frontline workers is important. Getting buy-in from leadership within the local unit and within the facility to support the new way of working, and then having an organization that is supportive as well. And the factors that are important in sustainability are really, you know, quite common sense. If the new way of working is easier than the last one, is better, if you can adapt it because the world is always changing, and if you can monitor it easily so you know when to adjust it, that's going to be more sustainable. If the frontline workers were involved and they like the new way of working and they made it, and if they have the skills to continue to monitor and adapt it in the future, and if they have permission and are allowed to make adjustments in the future, that will be more likely to be sustainable. And if the unit and facility leadership is involved in sustaining and developing and sustaining the new way of working and is appreciative and encouraging to the frontline workers, that's more likely to be sustainable. And then organizations which have structures and systems that support frontline workers to monitor and adapt the new way and also support the new way of working with policy changes or with HR changes, that's also going to be sustainable. So, you know, there are different ways of trying to improve care, which may work equally at the same level, you know, at the beginning, but will have different ability to sustain care. So let's just go through some examples. Let's look at trying to improve oxytocin administration, for example. So if the new way of working is that you are keeping preloaded syringes of oxytocin, so you're not having to do the work of loading it right after delivery when you're very busy, that's going to be more sustainable than, you know, just having posters or getting reminders from senior people that you have to give oxytocin. If the frontline workers are involved in adapting this new way of working, for example, they get to decide who is preloading the syringe, when they do the preloading, how to store the loaded syringes, and if they continue to adapt in the future as they get new ideas and as the patient load or staffing changes, that's going to be more sustainable than if they were just told what to do. You do this, you do this, you do this, by somebody in charge who doesn't quite understand the practical side of the work. If the unit is supportive, so if the nurse in charge likes this new way and then signs off on SOPs to train new staff in this new way of working, that's going to be better than if the nurse in charge is just simply monitoring data and then scolding nurses when the work is not going as well as it should. And organizations have a big role to play. So districts that are providing on-site support to facility staff in how to improve processes, which is a skill, and if they're also supporting learning between peers in different facilities about the practical details of what you do, who is preloading it, when they're doing it, how to store it, that's better than if the district is focusing solely on, you know, interventions like providing resources, clinical training, and monitoring. So the goal of our network is a 50% reduction in maternal and newborn death and improved patient experience. So that means that something has to happen at the level of the patient, right? We're only going to get better outcomes if the patient and provider interaction is getting better. Things that are happening in Geneva or capital cities or district headquarters that don't get down to the patient level aren't really going to do anything. And the things that can improve the patient-provider interaction, as we've talked about before, are improved resources, improved skills or motivation, and improved processes. And in the short term, you know, just by hard work, you can improve the interaction. So you can see bumps bumps of improvement without addressing processes. But it's almost impossible to do that in the long term and to sustain improvement if the processes themselves are not being adjusted. And this is critical for us. We need to use all of the tools that we have available, providing resources, providing training, providing motivation, but also thinking about the processes. And that's particularly important for getting a sustained result. So just to conclude what I've been talking about today, you know, sustainability might be something at the end, but you have to start thinking about it from day one. And it's influenced very much by how you engage frontline health workers, by how easy the new ways of working that you want them to do are, by how much benefit everybody sees, the frontline workers, the clients, the managers at the front line, and by the ability of frontline workers to continuously adapt and improve the new way of working. What works in June may not work in December. You have to tweak it. Okay? And then the other part that's important is that organizations that have in place systems to support frontline workers to continuously adapt how they're working, to make it better and to make it easier, are better at sustaining results. So let me stop there and take any questions. Thank you very much.
Thank you very much, Nigel. This is Bene. You got 3 questions during your presentation. The first one from Dea, asking if you have any tips to ensure that the change comes from within the clinical team, and that it really is, that the change is their baby.
That's a great question. And it's not always simple because we do have hierarchies that can be an issue. But when you're working with a new team, you want to keep pointing that out. You know, that having the supervisors isn't enough. You need to have the people on the QI team who are involved in doing the actual work. And you often need to keep bringing this up multiple times at every stage. So when you first form the team, you're asking, you know, if we're talking about delivery care, if we're trying to improve delivery care, you would ask which of the members have delivered a baby in the last 24 hours or the past 3 days or something. And if there is nobody there, you would want somebody on that. If you are talking about oxytocin, then whoever is involved in ordering oxytocin and prepping it, you would want them on the team. And when you're doing your analysis stage, so drawing flow charts or doing fishbone diagrams, you would again want to keep asking if the people who are involved in each step are involved. So it doesn't happen immediately, and it doesn't happen with a one-off thing. You just have to keep requesting that you are getting these people in. It's a good question.
Okay. The next question is how you deal with staff turnover when you try to sustain change.
Yeah, that's another great question too. So, you know, if the change itself isn't reliant on specific knowledge, right? If it's easier to do the work because of the change that you've made, that's sustainable when you have new staff. So, for example, you know, one really good example I heard about a couple of weeks ago. One of the hospitals we work with in India was having trouble with too many people coming into the postpartum ward. It was very crowded. Patients were not happy. Patients couldn't sleep. And so they wanted to do something to fix that. And the change that they made was to move the guard station from a hall where people could come in multiple directions. And so the guard wasn't able to stop every single person and talk to every person. But they moved the desk to a single doorway that was the only entrance. And so you couldn't go into the room without going through the guard and talking to the guard. And so a change like that will work. You know, it got good results. It decreased the number of people in the room, and it improved patient satisfaction a lot. And so that's very sustainable. Even if you have new staff changing, it doesn't matter. The guard will go and sit at that station and will know what to do. So the ideal is to find a change like that. You can't always. Okay, so sometimes you will have changes that do require you to orient new staff. And so that's the role of the managers that I was mentioning, that you want them to come up with a package to orient new staff on these things. And that needs to be put in place as well.
Sorry, I'm on silence, sorry. A question from Rajesh on in addition to international awards that come from being happy with the good results they start getting, how much is external recognition important to keep the motivations of the frontline workers?
I think it varies a lot. For some people it matters a lot, and for some people not much. But we tend to try and use it quite a bit. So when we're working with facilities, we try and work with them in groups, you know, maybe 15, 20 facilities at a time. And some of them will get results very quickly without much support from external people or much external validation or recognition. But some of the facilities will really want that. And working in a group like that helps, because the people who are getting results will get recognized by their peers and by their supervisors. And so we often find that not everybody starts initially, but once some people start getting recognition, more facilities want to get involved as well. So it depends, but you definitely want to build in a system where there is external recognition for the people who are motivated by that.
Thank you. You have a question now from Dr. Upandrao Dongre on how to validate QI data which has been recorded by the providers. He's worried that sometimes providers tend to over-report for the sake of reporting.
Right. Yeah, it's a good question. So you can make people over-report. You know, if you come in and scold people for doing badly, they will over-report. So that's one important thing. And the system does that. You know, there are lots of hospitals that have no neonatal deaths, for example. They never report them. They're hidden somewhere else. And that's because people get in trouble if they do report them. So, you know, it's not purely an issue of the health workers doing something wrong. They're sometimes forced to do it. So removing those pressures is one thing to do. But then to validate it and find out if you are actually getting real data, you want to compare lots of different data sources. You know, and that's why it's nice to often measure both different processes and different outcomes. And if the story doesn't fit, you know, if the processes are improving but the outcomes are not improving, you have a problem with data validity, and you need to go back and talk to them about that. We often, in our work, do external validation just as checks for ourselves. So we ask external people to come and do validation through, often through observation or by looking at other data sources. And you know, if you're working with the team properly, it's not that bad. They over-report, but not by much. And it's way better quality data than they often report to the government, because they are using it for their own purposes.
You have a question about being a victim of your own success, really, from Guilherme, who asks what happens when the volumes of patients gets higher with the increase of quality, and how do you keep staff motivated not to return to the previous stages where there were less patients and lower quality?
Yeah, that's a good question too. So we do try and do the trade-off, right? You know, some of the work that we try and support is related to efficiency as well, and that's important. So we don't want to get quality by working harder, or you know, because then there is a motivation problem. But if you're helping people to work in easier ways, that helps take care of some of that. You know, if you do have a problem where you become completely overloaded, then you will need to readjust a lot again. And a lot of the things we do to improve efficiency are related to records. You know, we're working with one facility here in New Delhi. Someone was just telling me they had 27 separate registers in the labor room. There's no need for that. So you can make a lot of time by decreasing, you know, record keeping and decreasing things which are not that valuable. And I think that is almost always going to overcome the extra work you're getting from patients coming because they know that you have better quality care.
A practical question from Elizabeth Buttrick. How do you get institutional support to actually support the frontline workers, to give them the time to think about the processes, to come up with the changes and monitor them while also doing the day-to-day work?
Okay, so it's easier in some cases than others. But again, you know, the workload of thinking about processes, coming up with changes and monitoring them is not much. You know, in the facilities we're working with, it's on average less than 10 minutes per day. And the trade-off is that they are working less on useless things, you know, less time on records and so on. So the frontline workers tend not to have so much a problem. Getting institutional buy-in to support frontline workers to adapt what they're doing can be harder. There's often a lot of mistrust from people higher up in the system about the abilities and the motivation of frontline workers. And they are often deeply skeptical that people are going to do this. So the frontline workers like it, but the higher ups are often skeptical until they see the results. Okay? And then I think once you start having results from facilities, and particularly when you have frontline workers presenting their results, you can get institutional support over time. Not everybody does it quickly. You know, it's not something that happens immediately, but you can work. That's what we tend to do. You know, get results at the front line and then try and get institutional support based on that. And initially, that just means permission. Eventually, we want them to put money into this. You know, we do want them to put in funding to support, you know, have staff who provide this support on how to do this, how to do the quality improvement process. But it's not a lot. And, you know, in India and in other countries, some governments are doing that already.
You have, at this point, two more questions. One from Teshome Desta Woldehana about how you prioritize changes that are sustainable and are high impact. And I think that was addressed in the first step 1. So Teshome, after Nigel answered, I will send you the link to that webinar.
Do you want me to? I'll answer quickly, sure. So, yeah. So I think this is again when you need the frontline workers, because particularly for sustainability, you know, if it's really going to be a lot of work, it's not going to be sustainable. So you need their opinion. The feasibility also comes into whether it's going to be high impact or not. But sometimes you need people with clinical expertise as well. So, you know, that's why you want a multidisciplinary team. So the people who are going to make the change will know whether it's feasible and sustainable, but the clinical experts, the doctors or the nurses or whoever you have, will have an idea about whether it's going to get the outcome that you want. And you need to discuss that as a team and come up with something that works for everybody.
You have a question from Zainab Naimi on the role of the district in enabling and encouraging facilities in continuing QI project. Do you have any example of what role the district, any good example of what role the district can play?
Yeah, so the India example that I showed you was the district. So the first 5 facilities were being supported by us as a project. The 38 facilities that started later were being supported without us. They were being supported by district systems. And so I think they play a couple of different roles. And what they did in this district in India, the roles were, first they were, set the expectation that the facilities would use quality improvement methods and would send data showing improvement. So that was clear. They had to improve oxytocin administration, essential newborn care, and a couple of other things, but that was the data I showed. So they set the expectation, and then the second important part was they provided support. So they didn't just delegate the improvement role, they helped them. And that was the lag period that I showed in these districts. I guess I can go back here. Sorry, let me. That was sort of the lag period in between when the 38 red facilities started and when they got the big improvement in September. They were setting up the system there, which was that health supervisors, which were people already employed in the government but which were somewhat underemployed, were trained as quality improvement coaches and given a schedule of facilities they were supposed to support. And then they also set up sharing meetings between the different facilities. So that worked well, and we left this district in November 2015, and last month these facilities were still going ahead. Everybody was getting oxytocin. They had data showing that the system itself of coaching wasn't working perfectly, and we're trying to address that now at the state level. But that's the district role, to set the expectation of using quality improvement approaches, of setting the expectation of improving specific areas, and then providing support on how to do it.
And finally, a comment from Rajesh Mehta saying the Southeast Region Office at WHO invited teams of clinicians and hospital managers as a team, and it worked well for the team to go back and practice because the manager was already oriented. So maybe Rajesh wants to share a bit more information about that.
And I think Rajesh is going to be talking about that in maybe a couple of months' time.
Okay. I think this is all the questions we have for you at this point. Is there any more questions for Nigel? If so, please type them in the chat. If not, we can close early today. I know Guilhem has a few words to say and a raised hand point to do with you.
Yes, if you were wondering actually if you prefer to have a shorter versions of the webinar, like half an hour instead of an hour. So if you think it's a good idea, you can raise hands. You just raise hands, it's small hands on the side, and you just let us know what you think.
Who wants half an hour webinars instead of an hour? Click on the raise hand button, which is just on your screen next to your name.
We have 3 hands. Okay, maybe not. So we're 4.
4 out of 31, so definitely not half an hour.
Okay, not yet now.
And people are commenting in the chat that 60 minutes is good.
Ah, yes. Okay, cool. Okay, great. So thank you, everyone. The recordings of these sessions can be found online on the website qualityofcarenetwork.org. The tab is the network, and it's under the network activities. So thank you, Nigel, for your great presentation, very clear. And Bene and absolutely all participants, please spread the word so we can all fight and move quality of care forward for mothers and newborns. Thank you very much.
Thank you.
Great. Thanks, everybody. Bye-bye.